Thank you. Thank you very much for inviting me. It's a real pleasure to come here, even though it's a very difficult week for the United States. I'm going to talk about, as I've been asked to, about elder abuse and its prevalence, in particular some work that my colleague Claudia Cooper and myself have done. Can I have the next slide, please? Although I can do this. Right. This is the. Doesn't matter. It doesn't matter. It's the wrong presentation, but it'll do fine. Right. Sorry. Can I? There we are. Okay. The elder abuse has been defined, and we're tending to, I think everyone here is using it, as a single or repeated act or lack of appropriate action occurring within any relationship. And I'd like you to just think about where there is an expectation of trust which causes harm or distress to an older people. And by its nature, it is often secret and hidden. And what made me first interested in this field was part of my clinical work, where there was an older people's ward, a long stay ward for people with very severe dementia, who by their nature are of course unable to communicate about whether they are being abused. And a window cleaner saw people being abused and through the window and reported it to the chief executive of the trust. And in a massive investigation called the Beach House investigation, discovered that there was a sadistic and abusive ring of nurses working within the ward who all knew and abused these vulnerable people. And occasionally student nurses would come into the ward and see it and would be threatened when they said they were going to report it, and none of them did. They were told they would lose their careers and be branded as a liar. And some of these nurses, I didn't work with any, but I had known, I'd seen in corridors for years. And I was completely shocked, not just as a human being, but to know that these perfectly normal looking colleagues had taken a job with vulnerable people, not because they cared, but because of their vulnerability. So that's when I first started to do the work on elder abuse. As it became clear to me, I mean, we're talking about having a feeling. I had no feeling about it. It never crossed my mind. And I thought back over the years from when I first became a doctor and how I'd sometimes be called. I first worked in an old mental hospital which had now closed down. And sometimes I remember being called and saying that this older person had fallen and burnt themselves on a heater. And at the time it never crossed my mind. And then I realised, I thought it was highly likely that this person had been tied up or restrained and that had caused them to be burnt. And my complete lack of awareness of the possibility of abuse had led to it being able to continue more. And it wasn't just me, it was a general culture that nobody had thought about it. And also the isolation these people had with really no visitors and doctors coming at a specified time allowed secret and abusive things to go on. So I began to think about that, and then later on I was asked about whether I could think about a European study for the minimum data set, and we began to talk about abuse there, and and we went on. So I went on to think more about what I'm going to talk about it today. And I've become aware that it's very difficult to measure, not only because it's hidden by its nature, but because people don't really agree what it is. As somebody's already mentioned, the idea of its disrespect and isolation in the Chinese. But within Europe, we don't really regard disrespect as abuse, although it may be experienced as abuse. There's also legal differences, and I've done some joint work with Australia, and within the UK it's illegal to allow someone who is not able to make a decision not to wash to the extent that it harms themselves, so their skin begins to break down. That's not illegal within Australia and is not classified as abuse. And there's also opinion differences. We've done a series of studies where we've presented a vignette and asked people whether the way that the person responds within the vignette is abuse or a reasonable way to treat somebody, and with a variety of reasons in between. And there's a very marked difference of opinion between individuals and between different professional groups. So people aren't sure what it is or how it should be defined. And secondly, how should we find out? Who should be asked? And the different possibilities, I'm just going to go through them. Adult protection services, third-party assessment, older people, family and professional carers, or the police. So starting off with thinking about third-party assessment. And again, talking about the feeling that you have that somebody is being abused. In 2003 and 2006, there were 2 studies using the minimum database healthcare, which asked researchers who were going into people's homes to say whether they were being abused. And the definitions of abuse are written up here, and I think they're quite a high threshold, saying that somebody is fearful, they had unusually poor hygiene, unexplained injuries, broken bones or burns, they look neglected, abused or mistreated, and they're physically restrained. And they both came up with very similar numbers, 4.7% by Sugarman in the United States and 4.6%, a study that Claudia Cooper and myself analysed from Europe. Interestingly, it was different between different countries, and whether it explained it or not, we thought it might, that the countries that it was higher, Italy and Germany, had much less community services and support. And so we thought that perhaps that was because people abused because they didn't know a way of managing and they didn't have any help to manage. It is reliable, but we then did some work with a community sample of our own where we asked researchers to fill in the minimum data set, and we also asked family carers to fill in the modified conflict tactic scale about whether they had abused somebody. And the many more people told us that they had abused people than the researchers picked up. So these estimates are far too low. Next idea is to ask older people about abuse. And this is a systematic review that we published in 2006 of different studies. And there is a clustering of most of the studies, around about 5% or so. And the biggest one is Ogden Bennett, which I'll talk about in a minute. However, since that time, there's been another study in the United Kingdom which is funded by a charity called Red Nose Day, where people dress up as clowns, and they excluded cognitive impairment and came up with quite low numbers. They used the Pillemer criteria of any physical abuse, but verbal abuse had to be 10 times or more in a year before it counted, and came up with 2.6%. But the really interesting thing is they talked about what an expectation of trust was, and if they broadened it to include neighbours and acquaintances, who they defined as you don't have an expectation of trust, it went up to 4.6%. So I think their numbers were far too low. They didn't ask anyone with dementia. You had to have it 10 times or not. But I think the really interesting thing is whether you include expectation of trust or not, and it sort of doubles if you don't. Ogden Bennett interviewed 589 older people, and they also didn't have dementia, came up with 6% any verbal abuse and 2% physical abuse occurring recently, whatever that might mean. And Pillemer said 3.2 and 2%. So, most studies seem to agree that if you ask older people, about 5% of general older adults are at risk of abuse, but most exclude the most vulnerable adults, which are the adults with dementia, and therefore exclude most people who might be abused. Beach, who's here today, he reported that when you asked older people with physical disabilities, about a quarter screened positive for abuse, and he used the modified conflict tactics scale, And he validated that by comparing the care recipient and the family carers reports, which were similar. And what that does, it asks a series of questions about how you, what you do when you're looking after someone or when you're being looked after. And you go from never to all of the time, with sometimes which is two or more being defined as abuse. And Claudia and I went on to use modified conflict tactics scale to ask family carers about abuse. And what prompted us to apply for the grant to do this was the UK government publication called No Secrets, which talked about abuse and how it couldn't be secret and had a policy about abuse. And within that, there was a line which said there is no evidence that the family's carers being stressed or having affective symptoms causes them to abuse. And, excuse me, our clinical feeling, because both of us are clinicians as well as researchers, are that there may be sadistic rings within institutions, but generally family people who look after somebody look after them to the best of their ability. Not everybody, but generally. And that when they abuse somebody, they're abusing them because they can't cope. And but that was our feeling, and we thought we should do a study to find out whether that would be the case. So we did a sample of family caregivers referred for assessment, and we asked the caregivers whether they had we used the modified conflict tactics scale, and a third of them reported significant abuse. And of them, nearly 4% reported physical abuse. So again, high numbers of people reporting, and of course, high and shocking, but there will be a few people who are extremely abusive and doing it on purpose, and they won't be answering the questions correctly. So it'll be an underestimate. And again, we didn't ask about financial abuse, because I think financial abuse is different. It's not stress, it's stealing. And people don't admit to stealing when somebody asks them about it, when they come around and see them. Whereas these people, when you say, which is what we did say to them, sometimes things are too much for you and you act, and there are particular ways that people act. Do you do any of these? Obviously, lots of people do fill it in and say they do. We looked at if you use different definitions of abuse. So if you used any abusive act, so scoring ever behaving like this, then 52% of people said that they did act abusively. If you use the abuse cases using the modified conflict tactics scale, it was at least sometimes in the last 3 months, then that's 34%. If you use the Pillimer criteria of 10 times or more with verbal abuse or ever with physical, it went down to 21. And we asked professional panel when they would report it, and it went down to 6.8. So the prevalence is very varied depending upon how you define it. We did a structural equation model and to look at what it was that predicted abuse, and higher carer anxiety predicted abuse, as did higher carer burden, as did more abuse by the care recipient towards the carer. So it's not a one-way, in dementia it's not a one-way ticket. You have to think about it. So what I would call clinically neuropsychiatric symptoms, when somebody is agitated, aggressive, and sometimes physically abusive, makes the carer more likely to abuse. And interestingly, the carer providing more hours of care. So that may be related to just having too much to do, and people have talked already about some help. Adult protective services, just to move on from asking the family carer, where you get pretty high numbers. They've been analysed in the USA, where some groups are mandatory reporters. I'm quite interested why bankers are mandatory reporters and how they know. But anyway, other people, since nearly everybody else here is American, they can probably tell me. And most found less than 1% reporting to the Adult Protection Services over a year. And looking at all the other research, this is probably the tip of the iceberg. I think that's partly because it's not known and it's not seen, but also partly because people are concerned what Adult Protection Services might do. Do they take someone away? Are they punitive or are they helpful? Moving on from the community, and in the UK similarly, it's very low. Moving on to care homes, 64% of people, 64% of that is reported as taking place in care homes, whereas 70% of the financial abuse reported is for people living in their own homes, and that's not surprising because in care homes, families probably don't have access to the money. The perpetrators in care homes the perpetrators that report the Adult Protection Services were staff, then family, and then other residents. Generally, it seems there's more abuse to older people in full-time care, and they're obviously more vulnerable. The staff are less likely to love them than their family does. Though in Slovenia, they say it protects you. In the United States, 36% they observed and 10% committed at least one physically abusive act, and 40% reported at least one psychologically abusive act. Interestingly, this beginning of reports about resident-to-resident aggressive and abusive behaviour, and this needs to be about one episode a week per home. Overall, because I haven't got much time, I'm just going to say that we think that we've shown to our satisfaction that it is vulnerable people who are abused, vulnerable people who are difficult to live with, they have neuropsychiatric symptoms, alcohol problems, poor social functioning, they're isolated, and the family caregiver, depressed and anxious, are more likely to abuse, professional caregivers who are burned out and dissatisfied. And having a bad pre-morbid relationship makes it more likely, and occasionally people who have acted abusively towards the carer, when the carer becomes the dominant person, they return that abuse. So overall, I want to say that elder abuse is common, it's difficult to detect, it's underreported to authorities, underdetected by interviewers. Family carers tell us more, but some of them are probably denying it. It takes place in vulnerable, so excluding impaired populations underreports it. There's different definitions, different types and different settings. There's a minimum of 5% in the general population in a month. There's more than 25% at minimum in the vulnerable population, and about a third of people with dementia. The other slide, which isn't in this bit of it, is I want to ask, what next? We've started to do a study, which is a logical follow-on from our community study, an intervention study to tackle the risk factors. So we're tackling anxiety and depression in carers. It's not actually been published yet, but the odds ratio of the people in the intervention group in the randomised controlled trial is 0.48. So we seem to have halved it. That's probably an underestimation, because when we picked up abuse that in the people not randomised to the intervention, we had an ethical duty to inform the clinical authorities about it. So we probably underestimated the difference it makes. But I think that one of the big things that we should start to think about is to help the carers who really don't want to do it badly, and think about the other carers who perhaps do. Thank you very much for your attention.
So we will proceed, and please keep your questions and comments to the end of the three panelists. So we'll have Ron now.